Good afternoon. I'm excited to speak to you all today about my work here at the University of Utah as a BIRCWH scholar. My talk today is entitled Modeling Protection Through Preeclampsia. I don't have any relevant financial disclosures. And we'll begin today with a brief introduction to preeclampsia, as I know many in the audience will be familiar with this condition. It's typified by hypertension in pregnancy, correlating with end organ damage. We don't understand the full risk and pathogenesis of this condition, but know that it has a clinically significant impact, affecting approximately 10% of all pregnancies in the U.S. And it is detrimental to both the mother as well as the developing fetus, given the resultant placental insufficiency, compromised blood flow, and therefore delivery is indicated many times for the health of both the mother and the infant, and it is viewed as the only cure for preeclampsia. We've detailed many negative aspects of this condition, so it's hard to imagine how preeclampsia could be protective, but work beginning in the late 1990s and early 2000s, which has subsequently been validated, began to show us that infants born to mothers in the setting of preeclampsia demonstrated less risk for an ocular condition called retinopathy of prematurity than infants born at the same gestational age but to women without preeclampsia. The reasoning for this is not entirely clear. To understand this association better, we'll now discuss what retinopathy of prematurity is. And it's characterized generally as an abnormal development of retinal vasculature. It accounts for up to 40% of childhood blindness worldwide. And as you can see here at the top, these are pictures of infant retinas. You can see blood vessel structures, and you can see that they don't extend to cover the full tissue area that is pictured. And essentially, retinal blood vessel maturation is incomplete at the time of preterm birth because this typically does not complete until about 40 weeks gestational age. So the fact that the vascularization is incomplete is not abnormal, but for reasons we don't understand, this maturation process becomes aberrant in about 50 to 60% of preterm infants born prior to 31 weeks. And this can range from from a mild phenotype of aberrancy to a severe, completely blinding phenotype of aberrancy. For mild to moderate disease, we don't have any mitigating treatments or interventions. For complete blinding disease, we can intervene, as pictured here, by ablating the avascular retinal tissue, done now with laser treatment as our gold standard. And this does mitigate and prevent, in the majority of cases, a totally blinding eye disease. However, as you can imagine, this is associated with significant visual and ocular morbidity, and therefore is not a standard we want to adhere to going forward. A preventative model that can mitigate more aspects of the disease and while still preventing blindness is a preferable intervention. And so to understand ways in which we could facilitate this, we're going to first focus on the molecular pathogenesis of retinopathy of prematurity. As you can see here, infants are experiencing normal in utero retinal vessel growth, but at the time of preterm birth, they experience fluctuations in the oxygenation of end organ tissues, including the retina. And this is the predominant factor, we feel like, that informs the ROP pathogenesis. You can see that there's an initial phase typified by supraphysiologic oxygenation due to the supplementary oxygen preterm infants are given that leads to aberrancy in molecular signaling, but not clinical manifestations. The second phase here is a relative hypoxia of end organ tissues that is also typified by molecular aberrancy, but in addition to this, we see the clinical manifestations of disease that can lead to the blinding condition. Now, preeclampsia is interesting because we feel like it exits infants from this disease progression and facilitates more of a normal retinal vascular maturation for reasons that we have not fully uncovered. Now, this focus on prevention is not specific to preeclampsia. In fact, in the field, there's been quite an effort to understand if there are ways we can prevent infants from experiencing retinopathy at prematurity, as detailed here in a figure from a review article I did with a staff scientist in my laboratory. Unfortunately, none of these preventive treatments or interventions have sufficiently prevented disease to be used clinically. So our focus on preeclampsia has looked at some of the molecular mediators that may facilitate preeclamptic disease, but also in the setting of preterm birth be protective for the infant. And I'm going to speak to you today about one such factor that we've identified, the serine protease HTRA1 or HTRA. And we've found that women who have preeclampsia have less systemic expression of HTRA, and infants who do not develop ROP have less systemic expression of HTRA. And so it would appear from these data that higher levels of HTRA may be associated with higher incidence of ROP, and that in fact preeclampsia is mitigating ROP disease by reducing levels of HTRA. In fact, when we look at our ROP population and we look at HTRA levels in babies with and without ROP, we can see that there is a statistically significant association between the level of HTRA in the systemic circulation and subsequent development of retinopathy of prematurity. And in fact, we find that for every doubling of the systemic HTRA levels, we see a 2.3, an increase in the odds ratio of development of ROP by 2.32. So this was very interesting to us. To tie this more closely to the preeclamptic pathophysiology, we looked at the organ that interfaces the fetus and the mother, the placenta, and we theorized that the placenta would replicate what we were seeing in the systemic circulation in terms of HTRA levels, and we were happy to see that in fact this is what we found. So women who have preeclampsia have less expression of HTRA in their placental tissue than women compared with women who do not have preeclampsia, suggesting that this may be the source of the difference in systemic protein levels. And to further substantiate that our findings have a functional implication, we moved into a mouse model from a human model. And we essentially said, in humans, if you have more HTRA, you are more likely to have ROP. So if we give mice more HTRA using a transgenic model, do we see more ROP? And the answer is yes. We see more ROP in mice who have more HTRA, substantiating our human findings. Well, if we have less HTRA in mice, is this protective for ROP? Again, the answer was yes. We see less of an ROP phenotype in this mouse retina as we do in the wild type mouse retina. And finally, can this be used as a therapeutic intervention? Can we prevent the development of ROP if we pre-treat with an antibody that blocks HTRA, thereby reducing? The answer is yes. So if we compare an antibody that blocks HTRA to a control antibody, we see that there is less ROP when we block and reduce HTRA than in a retina that we don't. And this importantly was done prior to inducing retinopathy of prematurity in our experimental model. And therefore this does demonstrate a prevention as opposed to a treatment. And so I think this is really an important proof of principle that looking at the maternal and placental physiology and pathobiology really is a critical tool to better informing us about the molecular basis and potential treatments for infant disease. So HTRA is, I think, going to be a big part of this, but there may be other mediators. And I think exploring this in greater detail is going to give us even more tools to help mitigate the effects of this disease. And with that, I'd like to thank everyone in the lab who's worked so hard on this, as well as my collaborators at the Medical University of South Carolina, and certainly funding from the BIRCWH. Without this, I would not have been able to achieve this work. Thank you so much.